We'd like to welcome back Dr. Garayalde. Dr. Garayalde was raised in Puerto Rico, went to college at the College of the Holy Cross in Worcester, Massachusetts. I went back to Puerto Rico for medical school and then came here to Gainesville for training in psychiatry. She's had training in general psychiatry, child psychiatry, and is now a senior fellow in geriatric psychiatry. She's going to talk to us this morning about neurocognitive disorders and delirium. Welcome, Dr. Geriatric.
Thank you. Thank you for the introduction. Again, my name is Stephanie Gerialde. I'm a geriatric fellow at the University of Florida, where I also completed my adult residency training. And I did a bit of child psych as well. Today, we're going to be talking about neurocognitive disorders and delirium. And this is a basic outline of our presentation today. So we're going to go through an introduction. We're going to discuss normal aging process, go over the dementia syndromes, the epidemiology, types of major neurocognitive disorders, how we diagnose dementia, what the treatment of dementia is, and then we'll talk about delirium. And then finally, a little bit on ways to maintain, brain health. And finally, our conclusions. So just to give a general introduction, when you hear of the word dementia, what do you often think about, or how would you guys define dementia?
Memory loss, I hear over here.
Okay, yeah, that's a good start. So memory loss is definitely one of the first symptoms that patients or loved ones will present or will bring up to the physicians. But in general, dementia, it really reflects an impaired ability to think, to remember, or to make decisions. And in general, it affects everyday activities. It's not a specific disease, it's a syndrome that reflects the change in cognition. While dementia increases as people age, it is not a normal part of aging. In people who are over or 85 and older, about 1 in 3 individuals will have dementia. As people live longer, the amount of dementia will definitely increase as well. It is estimated that by 2050, about 88.5 million people in the United States will be about 65 years old or older. And among those, about 10.5 million people in the US will have dementia. So before we talk a little bit more of dementia, I think it's important to know what is normal brain aging. So I'm going to play this little video. Please let me know if you can't hear it. So that's what's not normal. As we age, our brain will undergo changes. Part of our gray matter will decline, specifically in the prefrontal cortex, which is important for like mood regulation, emotional regulation, as well as like planning and pre-planning. And the decline in the prefrontal cortex actually starts at age 20, or more or less about age 20. And then other parts that will, further decline in gray matter will be parts of the temporal lobe, specifically parts of the hippocampus, which is where we, the parts associated with learning and memories. In terms of the white matter volume, well, white matter volume will decrease more than the gray matter, and specifically it will be affected in the front area or the frontal region, which is important for like executive functioning. There are some things that kind of are associated with high cognitive function in older individuals, such as here it talks about intellectually engaging activities like doing puzzles, careers that involve high complexity, high educational attainment, physical activities, doing exercise, gardening, dancing, and social engagements. So here we're focusing on different kinds of cognitive functions in the brain. There's two main forms of intelligence. There's crystallized intelligence, which is in general skills, abilities, and knowledge that we learn throughout throughout life. It's well practiced, it's familiar, it's stuff that pretty much is expected to stay stable throughout the aging process. Fluid intelligence, on the other hand, involves more about problem solving, reasoning. It's not so much about what you know, but your ability to take the information, interpret it, and manipulate it and use it to engage in your environment. Fluid intelligence does peak by the third decade of life, but then declines shortly after. Processing speed is part of fluid intelligence. It's the speed in which cognitive activities are performed, as well as speed of motor responses. And it will start declining also around in the third decade of life. Attention refers to the ability to concentrate or focus on specific stimuli. It is also part of fluid intelligence, and parts of it will decrease with aging. So working memory specifically will decrease with aging, but then simple tasks tend to stay mostly stable as we age. In terms of memory, I put this graph here. These are some things that will decline with age and parts that will remain stable with aging. So delayed free recall or retrieval of information tends to decline with aging. Our ability to identify where our memory has come from also tends to decline with aging. And remembering to perform intended activities like needing to, like they've listed here, taking your medicines before going to bed, that will also decline with aging. But in general, we're expected to be able to maintain the ability to retrieve information when given a specific cue, to connect like time sequences of events, and kind of remember how to do things like ride a bike, tie our shoelaces. That is expected to stay pretty much stable throughout aging. Language is kind of a combination of both crystallized and fluid intelligence. It does not generally decline with aging, but visual confrontation naming can decline after age of 70. And verbal fluency will also decline with aging. Visual spatial is another one that's a mixed type of intelligence, crystallized and fluid. Simple task like recognizing objects, recognizing familiar objects, and spatial perceptions are generally not affected by aging, but complex tasks like putting together furniture tend to be affected by aging. And then executive functionings is our ability to allow a person to successfully engage in independent, appropriate purpose and self-serving behaviors. Basically, it's the ability to self-monitor, plan, organize, and be mentally flexible. It is part of the fluid intelligence, and it will decline with aging.
Dementia is a word we give to a set of symptoms affecting different aspects of thinking and brain function that get worse over time and affect the way we live our lives. Dementia is not a normal part of aging. It is the result of physical diseases that damage the brain. Everything that makes us who we are, our personalities, intelligence, emotions, our hopes and our fears are driven by this incredible. The brain is the most complex structure in the known universe. Intricate networks of brain cells, bundles of nerve fibers, and hundreds of miles of blood vessels all work in careful unison to keep us ticking every day. Every second of our lives, nerve cells in the brain are firing. But when these cells become damaged and their connections start to break down, a person can develop dementia. The area of the brain where this damage occurs determines the symptoms a person experiences. If nerve cells in the back of the brain are damaged, a person's vision might be affected and they may have trouble reading words or climbing stairs. If nerve cells on the side of the brain are damaged, communication and language skills can change. There are 4 main diseases that cause dementia. The symptoms of these can overlap, sometimes making them difficult to tell apart. While each disease has characteristic symptoms, these can change from person to person depending on which areas of the brain the disease is affecting. Alzheimer's disease is the most common cause of dementia. Often, one of the first areas of the brain to be affected by Alzheimer's is the hippocampus. The hippocampus controls aspects of our memory and navigation. So, forgetfulness and getting lost are usually some of the first symptoms of Alzheimer's. In Alzheimer's, nerve cells are damaged by a buildup of 2 proteins in the brain, amyloid and tau. These proteins are present in all of our brains, but in Alzheimer's, they behave unusually and begin to clump together. Researchers are still trying to understand what triggers this, but it's likely to be a mix of age, genetics, and other factors such as poor heart health. The buildup of harmful proteins is also a key factor in other diseases behind the condition, like dementia with Lewy bodies and frontotemporal dementia. This damage spreads from one area of the brain to another as the condition progresses. So symptoms get worse over time and people begin to find more aspects of day-to-day life difficult. Dementia with Lewy bodies can affect different areas of the brain, leading to a variety of symptoms including changes in attention, sleep problems, and hallucinations. The processes involved in dementia with Lewy bodies are similar to those involved in Parkinson's disease, and people with dementia with Lewy bodies can also develop Parkinson's-like symptoms such as shaking and slowed movement. Vascular dementia can occur after someone has had a stroke or the blood vessels in their brain are in poor health. While the other diseases that cause dementia spread steadily through the brain over time, vascular dementia can progress in distinct steps after an event such as a stroke, slowing a person's ability to think, plan, and pay attention. Unfortunately, there is currently no cure for any of the diseases that cause dementia, and no treatments that can slow or stop the spread of these diseases through the brain. Researchers all over the world are looking for new ways to tackle these diseases and protect precious nerve cells. Their work has the power to offer new hope to millions of individuals and families whose lives are affected by dementia. To find out more, search Alzheimer's Research UK.
Okay. I think that was a pretty good summary and overview of what dementia or neurocognitive disorders are. But we're going to go into a little bit more information about it. So again, when I'm talking about dementia syndromes, I'm really referring, or another word I could be using is neurocognitive disorders. I'm using them interchangeably. Um, Neurocognitive disorder is a term that came with the DSM-5, which is our diagnostics statistical manual that we use in psychiatry. But I'll be using them mostly interchangeably. So dementia is a clinical syndrome caused by a range of diseases or injuries. As we saw in the video, it could be due to accumulation of proteins. It could be due to cerebrovascular accidents, and it could be due to other causes too, such as certain medications, substance use, prions, which is also like a malformation of certain proteins that accumulate. So it could be caused, so it's a range of diseases or injuries. And it's considered chronic, meaning that it will likely not get better. It will affect cognition, which is the process at which, we obtain knowledge or become aware or interact with the environment. And it will lead to a decline for the individual. The severity of the decline will tell us if it's a major neurocognitive disorder or a mild neurocognitive disorder, but there will definitely be a decline in what the individual can do. It's not only going to affect the individual, it's going to affect his or her family, caregivers, and society at large. I know in the video, they kind of gave us some very specific examples of what's going on in terms of Alzheimer's versus Lewy body disorder versus frontotemporal disorder. But in reality, what we might be observing clinically might not yet reflect what is going on in the brain, meaning that someone who might have a lot of symptoms that might be more specific for Alzheimer's disease might actually have cerebral infarcts as well, and accumulation of tau, which would be more common in frontotemporal dementias. So it's just very possible that there's a lot more going on. So it's not always a reflection in terms of what we observe clinically and what's going on in the actual brain. Dementia syndromes. So these are the three big classifications that that we use. So there's cognitive impairments that are not dementia. So that's the very first one. Essentially, I like to view this as more or less like a normal part of aging, where there's some changes in our ability to think or in our memory, but it doesn't meet any of the criteria for a major or a minor neurocognitive disorder. So a mild neurocognitive disorder or impairment is kind of between a little bit the cognitive impairments that are not dementia and major neurocognitive disorder. Essentially, there is some neurocognitive dysfunction, but it does not affect a person's ability to care for themselves. They maintain independence. They can do normal activities of, like, for instance, so that, things like paying bills and cooking might be a bit harder, but they're able to do it. Now, dementia or major neurocognitive disorder is really a severe form of cognitive decline. It affects the day-to-day functioning. Again, it's going to affect cognition. It's going to affect one or more area of cognition, to be specific. There will be a decline, meaning This isn't something that they had during youth. This is something that develops later in life. And then there's an absence of delirium. Delirium is something I'm going to talk about later on. But just kind of like, yeah, remember that for a second. There will be impairments in terms of functional impairments, social and interpersonal functioning, and the ability to live independently will be affected. Neuropsychiatric symptoms are symptoms that we as psychiatrists tend to pay more attention to. So this would be the development of depression or anxiety, behavioral disturbances, and some occasions, some dementias might have some psychosis associated with it. There might be apathy or indifference. So that's what neuropsychiatric symptoms would be. It is very common, specifically in Alzheimer's dementia, for there to be neuropsychiatric symptoms. And then neurologic findings tend to occur further along in the decline. There can be some gait disorder, there can be some incontinence, they might develop seizures. In Lewy body dementia, where it can be associated with Parkinson's disease, and in that case, the gait disorder or I guess we could say the neurological findings could be observed a little earlier than what you would observe in the other forms of neurocognitive disorders. Now, this is a graph that I found in one of the papers. It's supposed to be comparing major and minor neurocognitive disorder. They made an error and they wrote major neurocognitive disorder twice up here, but I know they're referring to minor. But again, I just want to emphasize that major neurocognitive disorder will have significant cognitive decline in one or more domain, will interfere with independence, will require assistance with complex instrumental activities of daily living, like cooking, paying bills, getting organized. Minor neurocognitive disorder will have a modest cognitive decline. It will not interfere with independence. And then individuals will be able to take care of their normal instrumental activities of daily living, but it might require a bit more effort, or they might have to develop some compensatory behaviors or strategies in order to do it, like having to-do lists, or taking a little bit longer to do it, or requiring extensions to get it done. But overall, the independence is maintained. In terms of epidemiology, so the prevalence of dementia increases exponentially with increase in age and will double every 5 years after the age of 65. In higher income countries, about 5 to 10% of individuals 65 years and older will have dementia. And then the prevalence in lower countries kind of varies a little bit more. According to this article that I was reading, it seems that in like the sub-Saharan Africa, the prevalence was lower than in developed countries. However, in parts of Latin America, the prevalence was significantly higher. So I'm not sure what the difference was or why, but that's something that they noted. And then in the United States, there's a higher prevalence of dementia in African Americans and Latino and Hispanic populations. The incidence, meaning the new cases diagnosed of neurocognitive disorder per year, will steadily increase until the age of 85 or 95, and then it increases at a slower rate. The annual specific rates is about 0.1 at age 60 to 64, and then 8.6 at 95. The risk factors that are known to be associated with dementia, well, of course, again, age is the strongest risk factor, but age, dementia is not a normal part of aging. Women have a higher prevalence, but not incidence. So it's believed that this is likely because women tend to live longer than men. Lower educational levels tend to have higher prevalence. And then there's some genetic risk factors. So there is an allele called ApoE4, and individuals who have two of those tend to have higher risk of developing dementia, and they also have higher like cholesterol levels and higher heart disease. So it's just another risk factor. It doesn't mean that you'll develop it, but it's just something that they talk about. And then I already talked a little bit about some of the future estimates, but one thing that I didn't talk about was the estimated annual cost in healthcare. So what I found was that the annual cost for healthcare, long-term care, and hospice care for patients with dementia by 2050 will be close to 1.2 trillion, which is quite a lot. So as the video indicated, these are the most common forms of major neurocognitive disorder. So there's dementia due to Alzheimer's disease. There's dementia due to vascular disease. There's dementia due to Lewy body disease, which includes Parkinson's disease dementia or dementia with Lewy bodies. And then there's dementia due to frontotemporal degeneration. So Alzheimer's disease, like the video indicated, there's an accumulation of some protein that occurs in the brain. Typically, it will start around age 65. The estimated life expectancy from diagnosis until death is about 10 years. Like I said earlier, it's strongly associated with the neuropsychiatric symptoms. So about 97% of individuals with Alzheimer's disease will have some neuropsychiatric symptoms like depression, anxiety, behavioral disturbances. And this tends to, or before I say tends, so what is observed in terms of imaging or on brain biopsy is that, postmortem, like brain evaluations, is that the hippocampus has atrophied. Vascular dementia will often resemble Alzheimer's. Actually, before I move on to vascular, Alzheimer's disease is the most common form of dementia. It's the most common form. But anyway, vascular will resemble Alzheimer's dementia, but it kind of occurs with kind of like a stepwise decline where as opposed to like a more subtle progressive decline. So, and it's related to vascular events like strokes. So Lewy body disorder is kind of viewed as an umbrella term. So it incorporates the Parkinson's dementia and as well as dementia with Lewy bodies. Essentially what they're using to group these is that there's an accumulation of a protein called alpha-synuclein. Dementia with Lewy body is the most common type of progressive dementia after Alzheimer's disease. It tends to affect individuals who are 60 years old and older. Its early presentations tend to be deficits in attention, executive function, and visual spatial abilities. It's also it's characterized by very well-formed visual hallucinations, REM sleep disturbances, and fluctuating levels of altered consciousness. And then in terms of Parkinson's disease dementia, first the patient will develop Parkinson's disease, and then they'll develop the dementia. Typically, this occurs about 10 years after having an onset of diagnosis or being diagnosed with Parkinson's. And it will be very similar to the Lewy body. Frontotemporal dementia is the second most common form of dementia in individuals younger than 65. It's characterized by changes in personality, behavior, language. And then in terms of the brain, there'll be like atrophy of the frontal and temporal lobes. Now, these are other causes of dementia. Traumatic brain injury, HIV infections, prion disease, Huntington's disease, substance medications, and these are just to name a few. So if you are concerned that you or a loved one might have dementia or declined in your cognition, the first step would be to talk to your primary care provider. A neurologist or a psychiatrist might be involved or consulted, in the diagnostic process. And typically they'll want to assess like the signs, the symptoms, risk factors. There's some reversible causes of dementia, which we'll get to in a second, but they'll order some labs, maybe do some imaging, but it kind of depends on what they're observing. In terms of cognitive assessments, so there's some here. These are some examples of some like tests that you might be done when you're being evaluated for dementia. And this is a general screening tool. It doesn't necessarily tell us what specific type of dementia a patient will have, but it gives us a good idea of what the cognitive functioning is. Labs that might be ordered would be things like the thyroid, liver, metabolic panel, CBC, vitamin B12, and folate. So it's believed that like thyroid, hypothyroidism can mimic dementia. Anemia could also mimic dementia. So that's why they check for B12 and folate. And then of course you want to check for heavy, reversible reversible causes like heavy metal exposure. You want to check for syphilis, toxicology, and just other things. Head scans are not necessarily needed, but they're often obtained in order to, find if there's some tumors or if there was a cerebrovascular event, and it can kind of help differentiate some of the types of dementia. So again, these are some of the cognitive, assessment tools that we use. Gives us a general idea. When we're looking at dementia, we kind of want to make sure that, that this is a chronic condition, that it didn't, that's not, that reflects that there has been age appropriate decline, so that this isn't something that, you know, an individual had since they were young. We want to make sure that it's consistent with the DSM-5 diagnosis. Yeah, there is some treatment. There's pharmacological treatment and there's non-pharmacological treatment. Our pharmacological treatments are not necessarily very promising in terms of reverse, you know, they don't reverse dementia, but they can have some benefits in delaying some of the, you know, the symptoms. So there's medicines that will increase the amount of acetylcholine, which is necessary for, you know, thinking and for, you know, cognitive functioning. And then there's medicines that will reduce glutamate, which is considered cytotoxic or just toxic for the brain. So it will function in reducing the glutamate. The non-pharmacological treatments would really, you know, we would want to consider like the neuropsychiatric symptoms. So we want to think about, you know, environmental stressors, ways that we can reduce any environmental stress, ways that we can gently remind or reorientate. Yeah. So the next step is, what is delirium? Does anyone know what delirium is? Well, so delirium is an acute change in attention or overall cognition. This is not necessarily, or, you know, or I guess let me rephrase that. So this is something that will be acute or subacute. It's not something that will necessarily be chronic. It has an acute onset, it will fluctuate, and there'll be an alternation in attention, meaning a patient or a person might, you know, be able to pay attention in some times or be oriented at times, and then shortly after not be oriented. It is considered a medical emergency. So when this occurs, we really want to get an understanding of what, you know, what could have caused it. It could be related to an infection. It could be related to, you know, something as simple as dehydration or constipation. But we want to rule out what could be occurring medically and get a, you know, better understanding of what could happen. It can be associated with some behavioral outbursts, and even like some paranoid delusions and emotional ability. This is the DSM-5 criteria for diagnosing delirium. But essentially, it needs to be, you know, alternating. It's a subacute or acute. Yeah. So it's the most common complication in hospitalized patients over the age of 65 and older. In terms of like the prevalences, so between 11% to 42% of patients who are hospitalized, up to 30% of older patients in the emergency room, 2 to 73%, which is a very wide range of older patients after an operation might become delirious, and 1 to 2% of, you know, individuals in the community setting might develop delirium. Again, it is, you know, often associated with a medical condition, so that would make sense that it would be much lower in the community setting. So the incidence rate is about 70 to 80% in older patients in an ICU. And delirium is often considered preventable in about 40% of the cases. So again, maintaining proper hydration, assuring that a patient is sleeping appropriately, that they are, getting their nutritional needs, would be really important. So the most important risk factor for delirium is actually neurocognitive disorders. So dementia is the main risk factor. And then, of course, age. So being older than 65, males tend to be at higher risk of getting delirium, often having coexisting medical conditions, decrease in oral intake, dehydration, malnutrition, certain medications could lead to delirium, substance abuse could lead to delirium. Having sensory impairments like not being able to see well or not hearing well could also lead to delirium as well. The pathophysiology of delirium isn't really well understood, and there's a lot of hypothesis. But what I think the important one here is the stress induced by severe illness, trauma, or surgery. It will involve the sympathetic and immune system activation, and just a lot going downhill from there in terms of what's happening in the body. When we're evaluating someone for delirium, we do want to make sure that it's delirium and not dementia. So in dementia, you won't see that fluctuating level of cognition, whereas delirium, it does wax and wane. And you want to be able to differentiate delirium from depression, mania, psychosis, and making sure that, you're finding exactly what the causes are. This is a clinical diagnosis, so there isn't necessarily a specific test that we would use for delirium. A lot of it is based on what we observe and the history that we obtain. These are some, assessment tools that can be used treating delirium. There's pharmacological and non-pharmacological ways to manage delirium. The non-pharmacological strategies, I think, are the more important ones. So this would include, in a patient who's hospitalized, it would include having someone sitting with the patient and assisting with redirecting them or reorienting them, helping maintain the day-night sleep cycle. So you want them to sleep, at night and stay awake during the day. You want to speak slowly, allow time for them to be able to complete tasks. You want to make sure that they have assisted devices like glasses, dentures, hearing aids. You want to encourage them to get out of bed, go outside. You want to monitor bowel movements and bladder function, proper hydration, and make sure that they're not developing ulcers. And then in terms of medications, it kind of really depends on the situation, but we do want to be very careful with what we're adding to the medical picture. But in some cases, medications will be necessary in order to maintain a safe environment for the patient and for everyone else as well. Antipsychotics are generally some of the things that we would use. But we do have to be cautious because it could increase the risk or the overall risk of death in the elderly. We don't necessarily like to use benzodiazepines unless it's alcohol related, because it could lead to further disinhibition of the behaviors. Things like melatonin might be something that we would use in order to help regulate their sleep cycle. And we would recommend avoiding certain medicines that, would reduce the amount of acetylcholine. So things like Benadryl or hydroxyzine would be things that we would try to reduce. We talked a lot about, things that could go wrong with the brain, but according to the CDC, there's a lot that can be done to keep our brain healthy. Simple things like quit smoking, make sure that you're maintaining your blood pressure, doing exercise, having a healthy weight, make sure you're sleeping, you're staying engaged intellectually and socially, and you're managing your blood sugar. So aging is associated with some changes in our cognition, but dementia is not a normal part of aging. Major neurocognitive disorder, or what some refer to as dementia, it's a severe form of cognitive decline, and it will affect a patient's ability to maintain their independence. And then mild cognitive impairments, they usually will maintain their functional abilities. Delirium is an acute change in attention and cognitive function, and it's a medical emergency. And finally, by maintaining healthy bodies, routine sleep, and engaging with our environment, we can help reduce the risk of dementia. Do we have any questions?
Watch the microphone. Oh.
Hi, can you comment on some of the new medications that have just been formulated or just are in the news for Alzheimer's? I think there are 2 or 3 new ones that have been released, FDA approved.
Yeah. I think that's a great question, but I wasn't prepared to talk about those medicines. But perhaps what I could do is collect some information and provide it for you. Would that be okay?
Sounds good. Mm-hmm. And
Other questions here? Yes.
Thank you. I have a question about delirium. There was one slide where there was a big range in percentages. Is that because it is often misdiagnosed, or I don't quite understand why there would be such a big range in a few of those indicators?
Yeah. So let me go back to that slide. So
Yeah,
what we're
2 to
looking at
73 in particular.
Yeah. So in the community setting, patients typically are healthy, and the hope is that they're well taken care of. So in the community setting, where there hopefully is less medical complications going on, the incidence or the prevalence is pretty low. But once someone has a condition where they are either hospitalized or require further care, like in a nursing home, or if they're in the emergency room where there's like an acute medical issue going on, or after a surgery, then the prevalence is a lot higher. So it kind of has to do with the level of medical urgency that's going on.
I think the question was more oriented towards the issue of why was the range 2 to 73% in the post-operatives? Why was that so wide? Is it lack of data? Is it misdiagnosis?
Yeah.
I don't know why there's such a wide range specifically post-operatively. I would have expected a much higher, for it to just be higher numbers. I wouldn't expect, wouldn't have anticipated it to have been such a low number to start with. I don't really know.
So a different question is, you hear a lot about the relationship between hearing loss and association with dementia. Can you address that?
Yeah. Well, so hearing loss, So in terms of association with delirium, I think would be a bit easier for me to explain. So a loss of orientation or an ability to engage in the environment, either caused by sensory disturbances like visual or auditory, could increase the risk of delirium. In terms of like the risk of developing dementia per se, I don't really know if there's a specific risk. I do know that in some patients, there's been a tie between, or there has been a reported symptom or known that some patients who lose the ability to smell have higher risk of developing dementia, but I believe that's related to it being in the temporal lobe per se, which is very close to the hippocampus. So in that there, I could see the, the sensory connection, but I don't know about, auditory and dementia development.
And then there's a question in chat. Is anger aggression in a person with neurocognitive disorder associated with a specific type or related to a person's pre-diagnosis personality?
Oh, that's a good question. So interestingly, as a person ages, a lot of those, personality traits that might typically be associated with aggression tends to kind of go away. And so the risk of aggression and behavioral disturbances is more comparable to other individuals with dementia. But early on, like in earlier phases, yes, people who do have personality disorders or have history of aggression do tend to have a lot more behavioral disturbances. Yeah.
And then there was a question that said, would we have your permission to share these slides after? Some of the data in the tables was a little bit small for us to read.
Yeah, of course.
All righty.
Of course. So this information I primarily obtained from my geriatric textbook and from looking through PubMed. But of course, and yeah, please feel free to share the slides.
Okay. Ken, was there another question to your left there?
Several times during your talk, there was a distinction made between incidence and prevalence, and I'm not sure what that difference is. Can you elucidate, please?
Yeah, so incidence is the amount of cases that are first time diagnosed in a year. So it's the new cases in a year. Prevalence is the number of cases that already exist in that year.
Okay, well, we'd like to thank Dr. Garayalde for an interesting lecture and wish her good luck in her psychiatric career. Thank you very much.
Thank you again. Take care. Stay well, everyone.